Hello, and welcome to On Becoming a Healer. Hi, Saul.
Hi, Stefan.
We're inspired a bit here by an article that was in the New York Times titled, When Doctors Use a Chatbot to Improve Their Bedside Manner. And essentially in the article, they describe physicians turning to GPTChat and finding out that in several instances, GPTChat produced language that they thought would work with their patients. And I think you're a little bit troubled by this finding. Saul, you want to tell me why this really grabbed you?
Yeah, Stefan. So as you know, I've spent many years studying physician-patient communication and the doctor-patient relationship. My book on becoming a healer is about that. And before this GPTChat article came out, I happened to be visiting several different medical schools around the country as a guest speaker. I had a chance to watch how they were teaching doctor-patient communication. And I'm starting to make some connections between the way I'm seeing it taught and what we're starting to see in terms of physicians turning to basically, talk about irony of ironies, turning to artificial intelligence to help them have difficult conversations with other humans. But before I get into kind of the research that I've been doing and some of the things I've been learning while on the road, I just want to kind of elaborate on this article because I thought it was so interesting. First of all, the article cites some national surveys showing that a large proportion of patients are pretty negative about how their physicians relate to them. They cited one study in which it says here 39% quote, said that they think physicians are generally not effective communicators. And for those of us who study this and follow it, that wasn't surprising. In this New York Times article, there was just physician after physician who said they basically loved GPTChat for being helpful to them in difficult situations when they weren't sure how to communicate. And one of the ones that stood out for me was an example of a physician who actually described having to talk with apparently a friend who had an advanced cancer diagnosis.
Oh, yeah.
Yeah, and this friend had essentially said, will I be around in 2 years? And this was for some important life cycle event. And so what happened is the physician wasn't sure what to say to his friend because obviously he didn't think this was going to be a good outcome. And so GPTChat came up with the following, quote, I admire your strength and your optimism, and I share your hope and your goal. However, I also want to be honest and realistic with you, and I do not want to give you any false promises or expectations. I know this is not what you want to hear, and that this is very hard to accept. So that's the quote. And the physician said that this quote, blew him away in a good way, meaning that he was pleased. He thought this was a great thing to say to his friend. And so a couple of things went, at least through my mind, looking over this. It struck me as being very generic, right? It's not, there's nothing negative about it, but it kind of reminds you of like buying a greeting card for somebody or a happy birthday card. It doesn't in any way reference, and of course it can't, anything that's specific about the person who is the physician, the person who is the patient, the nature of the relationship between them. All of that is just not there, of course, because it's been generated by something in this case that has no reference to the two people involved. And so that's why it kind of has this kind of bland quality to it.
Yeah.
If I think of myself as being the patient and somebody said that to me, who was my friend, I would just be kind of weirded out. Like it would just seem like an odd way of relating, given its sort of distance, if you know what I'm saying.
Well, yes. I'm looking again at, I admire your strength and your optimism, and I share your hope and your goal. Almost implies that the person had strength and optimism, which may not even be true. And yet somehow in ChatGPT's world, that's the way you begin a sentence.
Yeah, but you think also in like real life, I imagine what I might say to, God forbid, if you were deathly ill or vice versa, I'd be like, something like, Stefan, that's awful. That sucks. I'm so sorry. I don't know. It would emerge from
who we are.
Yeah, who I am, who you are, our very long-standing relationship. And so this language is kind of odd. Now, the other thing that's interesting about it is that the physicians like it. And so, at least from my perspective, it raises questions about whether they've grasped the nature of the relationship between two people, one doctor, one patient, but fundamentally two people, where there should be some human connection, where there is some relationship, some history. And the fact that someone would look at this text that's generated and think that it, quote, blows them away, that it's great, leaves me thinking that something is missing, at least from my standpoint, in terms of their understanding of the nature of the doctor-patient relationship.
Well, when I was starting as a medical student, I did feel kind of scared at times about how to have a conversation or how to speak to somebody, particularly if they were going to have emotions. I remember one interview where I think it was with a real patient who had come into the class who was describing a pretty tough life situation. And I was being videotaped. Yes, we had videotape at the time. And the patient began to seem intense and maybe almost tear up. And After the video was recorded, and I don't know how I responded, but the teacher, who was pretty smart, looked at it and said, how did you think about them tearing up? Were you scared? I said, yeah, I was scared he was going to cry. I was scared. He's like, you were scared he was going to cry? I was like, yeah. And he didn't offer some great wisdom. He didn't say, crying is a sign you've achieved something. He just said, that's interesting. That's an important thing, that you actually are scared that a patient's going to cry, because that's going to happen when you take care of people. They may cry, and that will just be part of what happens if you're engaged with them. He said something like that. But I remember specifically thinking at the time, all kinds of shit can go down here. What the hell am I going to do? And being kind of like a deer in the headlights. And honestly, we need to talk about how students are taught, because some part of me sort of wanted a little formula as to what to do.
Yeah, so I think you're getting to the crux of where I think this debate should be, which is striking this kind of balance between providing specific guidance and allowing emerging physicians to find their individuality, to confront some of their fears and their vulnerabilities. When I was at a few of these medical schools, I actually saw a set of acronyms that are now widely used to teach physician-patient communication and the relationship. There's an acronym PEARLS, PEARLS, which stands for partnership, empathy, acknowledgement, respect, legitimization, and support. That's a widely used acronym these days. And actually on the website of a leading medical school, they give examples of what to say for each of those. So for example, for partnership, it says, I know we both want what's best. And for empathy, they have...
Let me do the empathy one.
Yeah.
This has been a really tough day for you. I can see that.
Yeah, exactly. So again, this kind of has the same feeling as the bot, right? The ChatGPT. These are just generic things you can say. And I think there's nothing wrong with these frameworks. In fact, they're quite useful. I think there may be value in teaching them. Another one that's very common is spikes. And spikes is for giving bad news. And I'm just looking here now at the spikes.
Oh yeah, let's go through that. So
yeah.
S is for setting up, P for perception. I don't know what that means exactly, but I for invitation, K for knowledge, E for emotions, and then S for strategy summary. And I sort of get that. Like after they process the emotions, you're going to give them a strategy and a summary. And honestly, now that I read it, I think, oh, that's pretty cool. I'd like the idea to remember that we have emotions and then we go to strategy. That sounds really desirable to me. Again, Are you complaining about something fundamentally useful here?
It's interesting because I had this conversation with one of the faculty preceptors recently when I was visiting a school. She was very experienced. She's worked with a lot of medical students and standardized patients. And she came up with a really interesting analogy. She said, this is kind of like the debate around whether in religion, teaching ritual leads to a sense of spirituality or whether you need to be spiritual in order to embrace ritual. And, I'm Jewish. And in Judaism, I remember what we were always taught is just follow the rules and you will eventually feel spiritual. Just keep kosher, observe the Shabbat, do all the stuff, all the commandments, and then the spirituality will follow. And she's sort of making that case. So just learn the pearls, learn the spike and all that kind of stuff. And then eventually you will start to form connection with patients. You'll start, the good stuff will happen and you need that structure first. And I think it's a plausible argument. I think the problem with it is I don't think it's happening. Obviously, this New York Times article kind of evokes that. The incredibly high levels of discontent among patients who are surveyed raises that concern. And then just to talk a little bit about the research my team does, as you know, we audio record thousands of physician-patient encounters, and we analyze.
These are with consent, or at least the doctors know that they would be recorded. We don't want anyone to think this is done in a secretive way.
Yeah, and when I was preparing for this episode, I asked one of my audio coders to just pull some examples of great interactions that she thought were great, ones where she thought it was pretty bad, and ones where she thought it was kind of typical. And I actually think the typical is most interesting because, of course, it's typical. And so in this particular example, and I've changed the name of the doctor and the patient. Doctor walks in and says, hello, I'm Dr. Jones. Is this your first time here? I understand you're here to establish care. And the patient says yes. And then you start to hear basically a bunch of typing followed by these short questions. And so the doctor says, are you single or married? Do you have kids? How old are they? Are you working? What's your occupation? Are you sexually active? And then at a certain point when the doctor seems to have filled in all whatever boxes they have to fill.
And they're typing. They're typing.
And click. They stop and they say, okay, how can I help you today? So first they had to get their busy work done. Then the patient says, can I get Viagra? And then before the physician can answer, the patient says, can my heart take it? And the doctor asks, do you exercise? How long? And, and so on. And then later on, the doctor asks, do you have erectile problems? The patient replies, it's on and off. And then she asks, are you having erections in the morning? And the patient says yes, and so on. And I think what's interesting is all of these are appropriate questions. They're all appropriate. We know that you're trying to assess whether somebody has any cardiac risk issues. We know that morning erections can be useful information if you're trying to separate psychological versus organic causes and so forth. All very appropriate. But what's interesting when you're listening to this is that it seems like a service provider. In fact, before the doctor-patient encounter, there's an encounter with a medical assistant who's like, have you taken your medications today? Do you smoke? When was your last colonoscopy? And all that. And it sounds the same. It's like so similar. And I'm thinking to myself, wow, there is a chasm between this and pearls or spikes or anything that is happening. And in fact, most of the encounter doesn't involve intense emotion. It doesn't involve having to go, well, in the case of the New York Times article, having to go to a bot to find out, how do I tell this person they have cancer? It's more just the whole relationship itself is very task focused and kind of just driven by the computer feeding agenda. And so I think, again, it just reinforces the fact that whatever is happening, there is in the training we're giving to physicians and the many things that happen between then and what we're seeing when we get to attending practice, it's not working.
But, well, could it be working? That is, isn't this working very well? Like it's getting a lot of information that is considered appropriate to get. I mean, I know you don't like it emotionally, but maybe it's working really well.
A couple ways I would answer that. First of all, patients obviously are not satisfied when serving.
Okay, they don't like it.
They don't like it, yeah. Yeah. So the question, of course, is, and this is an age-old discussion. There are some physicians that say, who cares if we don't really relate to patients? And who cares if they don't think that we're sensitive? I mean, after all, it's all about being technically good, right? And so there's certainly that argument. I think that argument's been debunked many times over. And I don't even think that the people who are teaching medical students would embrace that argument. Like, if you talk to people who are teaching doctor-patient communication, they wouldn't be, well, who cares if this is all failing because it doesn't really matter anymore. I don't think anyone would say that. I think there's a general understanding that the relationship is profoundly important to patients adhering to the treatment. Yeah, exactly.
You've defeated that issue.
Yeah, I think so, absolutely.
So let's just concede there's something unconnected or disconnected or not really natural about this interaction. My next theory of the problem is that it's nothing to do with the doctor. The problem is that someone put a computer in the office and said you need to get stuff into it. And this computer is changing, or the electronic health record, or EHR, is changing everything. And maybe the real problem is that we've allowed this device to intrude. Is that a fair argument or a fair analysis of the problem?
Yeah, I think it's an important part of the argument. I've talked about, I'm not the first, but talked about how it's become the doctor-computer relationship and the patient becomes like a data source. That's supposed to be the other way around. And so clearly, physicians are distracted by the EHR. Often they don't feel like they have enough time to write their notes later, so they're doing it during the visit. And so it becomes this data entering while talking to a patient that, we hear so often. So I do think the computer is a part of it. Some physicians are better able to negotiate or navigate that triad than others. But I also think it's important, at least from my standpoint, to say that I don't think there ever was a golden era where physicians were regarded as fabulous communicators with patients. If you go back 20, 30, 40 years, physicians were often considered very paternalistic. They tended to be male. There were tremendous power imbalances that were part of that problem. And so I think that to say that this is just about a computer is unfortunately not, it's not that simple. The other thing I'll say is that we actually do hear positive interaction in the current era while the physician is working with a computer. And actually one of the ones I listened to was a interaction between, in this case, a clinician who was seeing a patient who he knew. And at the beginning of the visit, the clinician said, how are things going? It's been a while since I've seen you. And the patient replied, people been dying in my life. And then he later mentioned, shortly thereafter, he alluded to a son and a close friend. And that was the opener. People been dying in my life. And the clinician's response was, from my standpoint, just immediate and heartfelt. It was just like, oh, Mr. Simpson, I'm so sorry. It was just spontaneous. It was just clearly a human response. And then throughout the visit, that sense of caring and sensitivity to somebody who clearly was suffering was just part of the way in which this clinician was interacting. But the clinician was also professional. It wasn't just personal. They talked about counseling opportunities that they could make available. They asked how this individual was coping with their grief. They said, but again, it was juxtaposed with the personal. You have my phone number. You can call me if you need anything. Let me know if there's anything I can do. So it was a very personal response. And then they also got stuff done. They said, oh, your blood pressure looks great today. And so they were actually saying something kind of affirming. So the whole feeling of it struck me as very personal and also very professional. And the reason I keep saying clinician is that when it was over, I was like, wow, this is pretty amazing. And I looked up the clinician, and it turned out it was a nurse practitioner. So now, I don't want to imply that it's just because it was a nurse practitioner, although there actually is a lot of literature that shows that nurse practitioners often achieve the same level of outcome in primary care and even in the specialties. The data is not quite as strong on that, but with higher levels of satisfaction and connection with their patients. So I think that gets to the fact that, and I don't think that's because nurse practitioners are smarter than doctors. I think it's because there's something about the culture of medical training that is different, obviously. And obviously the people who are selected to go into it, and also the culture of practice. But there is evidence for that. But I'll even say that within the physician pool, and of which we have a very large amount of data, there's a lot of variation, a lot of physicians who are wonderful. And so I don't want to just say it's about the training per se, but I think it should give us pause. And we can't just, draw stereotypes. And by the way, the other sort of thing that was ironic is this nurse practitioner happened to be male. And then the kind of example I gave before, which was kind of considered typical, but was actually a physician who happened to be female. And again, so that even gender stereotypes we shouldn't be making.
Yeah.
And so I think it just goes to show that these things really depend on the individual, and but also I think on the kind of training and the culture in which that individual is developing as a professional.
So to recapitulate a little bit here, I think there's something you and I both felt was very frustrating about the first example, where the doctor is soliciting a history of a concern about sexual functioning that seems to involve a lot of typing and some very rote questions and no human connection. The second example sounds somehow like a natural statement. Oh, I'm so sorry. And there's a mixture of professional advice, support, but just basically being a person, a fellow human being who's not necessarily separated by that computer or by any other preconceptions. And that's sort of what we think gets closer to a healing and useful relationship. And part of what's driving all this concern is that, as it reported in the Times, there are countless surveys. One of ones I saw was that 3/4 of patients feel their doctors are not compassionate. That's a pretty high percentage, 3/4. It means there's only a quarter left who think that their doctors are compassionate. Two questions. One has to do with why, and then the other is whether we can fix it one way or another. Can I just ask whether the words empathy or sympathy have anything to do with this? That is, should I be telling my students, you really need to be empathic? Is that going to get us where we need to go? I don't even know what those words mean, by the way, just to be completely fair.
Well, these are words that are thrown around all the time in the communication education space. When I go to various places, everybody talks about empathy and sympathy. And in general, they say empathy is good, sympathy is not so good. There are many different, and actually, when you ask people to define these terms, and I've read the literature, there's not a lot of consensus. They're defined in a variety of different ways, but sometimes sympathy is seen as being like pitying of the person.
Yeah.
And empathy is considered to be something a little different from that. And I actually think that this conversation about feelings is not actually that helpful. I think, and actually, I can think of an example. At one of the medical schools I was at, I was watching a medical student talk to a standardized patient. There was a preceptor there, and then in the middle of it, the preceptor interrupted and said, "Oh, that was a very sympathetic statement. I want you to try being empathetic and try again." So the students stopped, and then they just repeated what they had said, but they said it in a way that was considered to be more empathic than sympathetic based on what they've been taught. And the preceptor was very pleased, and they actually slapped him 5. But to me, it was almost like, oh yeah, you just got like a multiple choice question right? But I think the question is like, what's going on here? I think that these are essentially feelings, and no patient ever benefited from something their doctor was feeling. They benefit from what their doctor does, how they interact, what they say, what they do. And I've always found it just more helpful to think of it as just, we want our doctors to be caring people and caring professionals. Caring to me is much more active. It's like when you show that you care for somebody, you're showing by your actions that you're trying to figure out how you can be helpful to them. Hey, Mr. Jones, you just said this, but then you just said that, and I'm a little confused. Can you please clarify that for me? Because I really want to make sure we get this right. Like that type of conscientiousness and effort and sincerity. Who knows what that person's feeling? I don't care what they're feeling. What I can see is that they care. They're trying to figure out how they can do right by that person. And I think patients can see that. And it's coming from, and it's authentic. Caring is inherently authentic. Again, that word's a little murky, but I mean, it's coming from the person. And I think to me that I find that helpful. I want my doctor to care about me, to care for me, and to show caring. What they're thinking or feeling, I don't know, but I can see they care. They may be, are they pitying me? I don't know what they're, but I can see the caring, and it's manifest in how much they're trying to understand where I'm coming from, what I need. And so I think that what it does is it encourages the medical student or the young physician to tap into who they are, and also to form connection, because I think it's when you connect with another person that you start to care about them. We don't just care for somebody walking down the street, or somebody who's starving in another country on a poster. That doesn't generate caring in us. That generates, well, it might generate pity. But I think when you start to care for somebody when you start to connect with them. And so the key here is to form those connections. And so my concern, the way in which we're training, the pearls and the spikes and the LERA, the whole bunch of acronyms, that while that's useful didactically, it's not adequate. And in some ways it can detract from the development of kind of finding your voice as an emerging physician. How do I draw on who I am to connect with this person?
I mean, part of me as a 50-ish doctor at that age, I get it and I feel it and I want people to see that I care. There's also part of me that wants to have a plan of words to say for difficult situations. And maybe I wanted that even more in my 20s, but it still can come up now where I feel like I just need to have a plan so that I don't stumble or I don't fall apart or I don't just say the wrong thing. And if you give me a plan, the patient says they're having something bad happen and you say, that must be hard for you. We could make fun of that. But I mean, to have these things that are planned also sort of lend a certain structure and give me a little bit of an anchor. I'm thinking about being a medical student in my 20s when I was arguably less mature, maybe not, but maybe I was, and certainly more anxious about my own emotional state, as I mentioned in that story where I was afraid the patient was going to start crying and I didn't know what I'd do. I think you're not rejecting this, but I just want to say having some scripted things that you can say sometimes feels really helpful.
I agree. And I absolutely think that it can be a necessary tool, particularly early on in training. But I think it needs to be combined with a kind of more interactive approach to teaching, where you would say, let's go back to young Stefan, who is a little freaked out about the fact that their patient is crying or might cry. And I think your preceptor kind of opened the window a little bit when I think you said he said something along the lines of, how does that make you feel? Does it frighten you? And I think you acknowledged yes, but I wouldn't have stopped there. I might have said something like, can you tell me what you're frightened about? What are you fearing? And so let's go a little further, because of course you weren't afraid the person was going to punch you in the face. You were actually afraid of the emotion it was going to elicit in you.
Yes.
Yeah. And I think that it's a fairly long journey to acquire enough comfort with self so that those emotions and those fears are not an impediment to being present when a patient cries. But I think medical school is absolutely a place to start that journey and to begin to have those conversations. And if you just fall back on the pearls and the spikes and you don't allow people to confront their discomfort and their fear, then I think you're not starting that journey and making it clear that that journey is ultimately the destination. I think that when I listen to these very generic recordings, like the one I mentioned before, where it's just a service, clearly that doctor has completely forgotten about or given up not just connection, but pearls and spikes. Like it's all gone. They're just doing through. Okay. And I think that one of the things that keeps those of us who love patient care going is the fact that connecting with patients is nourishing. It's actually rewarding for us.
Rewarding for us.
Right. And so when I'm with a, just speaking person, when I'm with a patient, forming that connection is actually nourishing for me. I'm speaking, I guess you could say selfishly here. When I walk into the room, forming that connection is what brightens me up, particularly if I'm tired, I've had a long day. And so I think if that experience is suppressed or not developed, instead you have spikes and pearls and that's all you have, then I think the spikes and the pearls goes out the window and all you're left with is the kind of checklist stuff that we hear, because the connection has just not been developed.
So if I'm a medical student, I'm listening to this and I think I want to really connect like a real human being. And my professors just told me that I need to learn pearls and spikes, and I'm going to try to do that a little bit, but I really want to do the real thing. How do they start? I realize they can't dedicate a whole episode to the real thing. In some way, that's the topic of many of our other episodes. But how can they, what's the question I can ask myself as a doctor or as a medical student or even a nursing student saying, I want to have a real connection in which I am helpful to this person. What do I ask myself so that I'm moving in that direction?
For one thing, I would suggest that you start to ask the patient questions rather than making assumptions about what they're experiencing. So if a patient says, people in my life have been dying, of course, you start by reacting with sadness and concern, and then you can ask them, how are you doing? And of course, the fear that the medical student has is that the patient's going to start crying, that they're going to start sobbing. And, my answer to that is, well, if you want to grow as a physician, have courage, lean in, try it, and go get a box of tissues. And if you keep the focus on trying to ask questions to better understand what the patient experiences are for the purpose of figuring out how you can help them, that's caring. And then I think that you may walk away from that feeling kind of good about yourself because you weren't shying away from your fears. I think at some level, we kind of know when we're shying away from our fears. And because at some levels, even if we don't acknowledge it, we know that we didn't ask that question because we were afraid the patient was going to cry. So I think that when you lean in and you start to take that chance, you'll walk away from that feeling like, I'll give you an example. So I was in clinic just a couple of weeks ago. My resident came to talk with me about a patient who it turns out was experiencing homelessness, and his patient's diabetes had gone out of whack. And the resident was frustrated because he said, I'm trying to sort out this guy's medications, and he's just crying. And it was almost like that was, from the resident's standpoint, kind of, maybe annoying is too strong a word, but for the resident, it was just kind of a distraction. Here I am trying to talk to this guy about the fact that his A1C's gone from 7 to 11. And he's just crying, and it was just a little frustrated. And so I went in there and I started to talk with this man about what was going on. And I asked him about his crying. He started crying, and he told me that he actually doesn't usually cry. It turned out he's been homeless for 8 years. He said he doesn't usually think about it that much, but when he's in the doctor's office and we ask him about it, he starts to kind of feel sorry for himself. He starts to reflect on his situation, and that causes the tears to flow. I asked him how he gets through the winter, and obviously it's warm now, but he said that he walks during the night to stay warm, and he sleeps during the day. He stays away from shelters because they're dangerous. I wanted to connect him to a social worker. Apparently they tried at a prior visit, but they couldn't reach him because his cell phone was disconnected. It turned out he has a sister who's kind of struggling, but she has a small apartment, and she's now actually paying for his cell phone bill. So that showed me that there's a real connection between him and his sister, and that we actually would be able to reach him using our social worker support services. Anyway, by the end of this probably 5 or 7 minute conversation, I kind of wanted to hug the guy. I don't know. I just felt there was something very sweet about him. His responses often surprised me when the resident suggested that we put him on Lispro 3 times a day, which doesn't make a lot of sense if you're homeless. The patient's response was, that would make me very anxious because I would do it, but I would be constantly worried about whether I'd missed a dose. And it wasn't the response I expected. And so just this sense of having an opportunity to talk with this guy from an extraordinary different walk of life and to just connect with him was just, I don't know, it just felt good, even though I'm not sure I helped that much, except for possibly getting a social worker to try to reach him again. But I think for me, that was nourishing. And I think that was, and yet for the resident, it was just kind of a distraction. So I'm sort of thinking like something isn't working here in terms of the trajectory. And this is not a cold resident or anything. It's just, I'm just saying there's something that's not working in the process of acculturating these young physicians, at least a lot of them. And that's the concern is.
So the culture of the program is that it is asking and assessing whether doctors in training collect certain information and carry out certain tasks that are related to the care of certain diseases. And the time you spent as a clinician interacting, absorbing this patient's situation may not look on paper like you collected certain information or instituted a new management plan to get the hemoglobin A1C down in a patient with diabetes. It may not look that way when the resident walks right back and reports about that case to their attending and says, well, they cried for about 7 minutes and I learned a little bit about where they live. So is the culture probably just kind of misfitting what our patients need?
Well, I think there's maybe a deeper question about the culture that it may not feel very safe for young physicians, for medical students, to take these risks, these deeply personal risks, to make themselves vulnerable because they constantly feel like they're being evaluated. They constantly feel like they have to look good. Like when I think back to this standardized patient encounter where the preceptor said, that was too sympathetic, you need to be more empathetic. I think what would be ideal would be a culture in which medical students could feel secure maybe even crying themselves if they feel confused or frightened during an SP encounter, feeling like they can start to take chances and start to begin to find a way to be themselves in relationships with patients. But to do that, you have to be comfortable being a little bit vulnerable. And I think the nature of the culture in which we train physicians, medical students initially, and then residents, it doesn't feel safe for many students. And so, and it's much more about, just learning to do what you think you're supposed to do. Whereas the personal and professional development that's necessary to become someone who can be comfortable and present requires some personal risk taking. And I think the culture that we've created is not conducive to that.
So maybe that helps bring us back to where we started, which is that if you've been suppressing some of the potential risk taking, if you've been, as a doctor, suppressing your curiosity in order to get information that you enter into the computer, then at some later time you realize you don't know what to say in response to some bad news. And you think, and patients are so used to this that apparently what ChatGPT can generate without even knowing the patient sometimes actually sounds better than what this doctor might say after 15 or 20 years of suppressing human growth.
I mean, I don't know how the patient feels about the response that comes from ChatGPT through the mouth of their doctor. But I know that the physicians, at least the ones who were interviewed in this article, felt like this was a great tool for them. And to me, that's a reflection of a failure of the culture of medical training, the culture of teaching physician-patient communication, the doctor-patient relationship. And that's the take-home message from this type of weird phenomenon where people are turning to a bot.
So if I go out into the world this week, onto the hospital wards or into clinic, I think my first step is to ask, is there a way to configure this interaction with a human being in front of me in which I am being an actual friendly, serious, caring human being to the person in front of me? It should include, as best I can, getting information and instituting a plan of care. But the plan of care will be a better one if I am actually caring, which strangely recapitulates a quote from Francis Weld Peabody in the early 20th century, who said words to the effect of, the secret to the care of the patient is in caring for the patient.
Yeah, that's right.
So Saul, we're probably near the end here. Are there any final thoughts you want to share?
No, I think that's a great way to close. When we were planning this, I was thinking about whether there was any pithy advice we could end with. And I actually think that this is one of those discussions where I hope there's just more conversation about, to some degree, our failings as a medical education system. We're teaching about the doctor-patient relationship and the need to reflect on how much it needs to be reconceptualized to some extent. Again, not throwing out the baby with the bathwater. I'm not saying we shouldn't teach some of these basic tools, but recognizing that that's not nearly enough, and that in the absence of some of the themes we've been discussing, it can backfire.
Well, thank you, Saul.
Thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.